Hello, everyone, and thank you for being here for this continuing education session. My name is Stephen Kemp, and I am a Doctor of Pharmacy candidate at the University of Technology, Jamaica. Today's presentation is titled Pharmacist Knowledge, Perspectives, and Readiness for Pharmacist-Led Remote Patient Monitoring Initiatives in the Bahamas. This session serves two purposes. First, it is an educational activity designed to strengthen understanding of remote patient monitoring, its clinical value, its limitations, and the pharmacist's role in safe implementation. Second, it contributes to my doctoral research by examining pharmacists' knowledge, perceptions, and readiness to engage with pharmacist-led RPM initiatives within the Bahamian context. At the start of the session, I will briefly review the information sheet, explain the survey process, and clarify how continuing education credit will be verified while confidentiality is protected. After that, we will transition directly into the educational content, beginning with a clear definition of remote patient monitoring. This slide summarizes the key points from the information sheet that has been provided to you. The purpose of this study is to assess pharmacists' knowledge, perceptions, and readiness regarding remote patient monitoring in the Bahamas, and to determine whether today's educational session influences those areas in a measurable way. Participation involves completing a questionnaire in two parts, one section before the lecture and one section after the lecture. Each section should take approximately 15 to 20 minutes to complete. It is important to state this carefully and transparently. Participation in the research component is voluntary. However, because the questionnaire also functions as the assessment component for this continuing education activity, full completion of both the pre-lecture and post-lecture sections is required in order for CE credit to be issued. The study involves minimal anticipated risk. The main burden is the time required to complete the questionnaire. There are no invasive procedures, and the information collected is intended for educational and research purposes only. Before we move into the survey process, I want to orient you to the objectives of today's session. By the end of this activity, you should be able to define remote patient monitoring clearly, distinguish it from telemedicine, identify where RPM is clinically useful, and recognize the pharmacist's role within realistic patient care workflows. We will also discuss safety boundaries and implementation considerations, because the goal is not simply to introduce a digital health concept, but to think critically about how RPM could be adopted responsibly and effectively within pharmacy practice in the Bahamas. In terms of structure, we will begin with the pre-lecture survey, then move through the educational content and case discussions, and finally return to the post-lecture survey. This sequence is intentional because it allows us to compare baseline understanding with post-session understanding in a structured way. With those objectives established, I will now explain how confidentiality, unique identifiers, and CE verification will be handled. Confidentiality is an essential part of this project, so I want to explain the process clearly. Within the research survey itself, no names or other direct personal identifiers are entered into the dataset. Responses will be reviewed and reported in aggregate form, meaning the analysis focuses on group patterns rather than individual participants. This study has received ethics approval from the University of Technology, Jamaica Research Ethics Committee, and the PHA-UWY Research Ethics Committee in the Bahamas. To support CE credit verification, a unique identifier number will be used. That creates a temporary administrative linkage, but that linkage is not part of the research dataset used for analysis. Mrs. Jewel Russell is the designated administrator for this UID process. Her role is limited to maintaining the temporary identifier record for verification purposes only. She will not participate in the study analysis, interpretation of findings, or reporting in any way that would compromise confidentiality. The UID record will be stored separately from the survey responses. Once CE credits have been issued with the Council, the UID linkage record will be destroyed. At that point, the remaining survey data will be fully de-identified, and no pathway will remain to connect an individual pharmacist's identity to a completed survey response. Before we begin the lecture, I want to briefly walk you through how the survey process will work. This is a structured two-part questionnaire that is integrated into today's session. You will complete the first portion now before the lecture begins. This captures your baseline knowledge, perceptions, and readiness regarding remote patient monitoring. After the lecture, you will return to the same survey and complete the second portion. This allows us to assess any changes following the educational component. The process is designed to be sequential, so it is important to follow each step carefully as we go along. To get started, you will access the questionnaire using the link that has been provided. The first item you will encounter is the consent statement. If you agree to participate, select yes and proceed. You will then be asked to enter your assigned unique identifier number. Please enter that number exactly as given. This identifier is used only to verify completion for continuing education credit and is not linked to your identity within the research dataset. You will then complete the pre-lecture section, which includes socio-demographic questions and baseline items. Please answer honestly. There are no right or wrong answers, and all responses will be kept confidential. As you complete the pre-lecture portion of the survey, you will reach a section labeled Part B, which looks like the screen shown here. When you get to this page, I need you to stop. Do not click Next and do not close your browser or the Survey tab. Please leave the survey open exactly where it is. After the lecture, you will return to this same page to complete the second portion of the questionnaire. This step is very important because it ensures that your responses are properly linked and that your completion can be verified for continuing education credit. If the survey is closed or restarted, it may not be possible to link your responses correctly, which could affect your eligibility for CE credit. I'll repeat that clearly. When you reach Part B, stop. Do not click Next and do not close your browser. Leave the survey exactly where it is and return to it after the lecture. You may now begin the pre-lecture portion of the survey. Please take approximately 15 to 20 minutes to complete it and follow the instructions carefully as you proceed. Once everyone has reached the Part B pause point, we will reconvene and begin the lecture. So what is remote patient monitoring? Remote patient monitoring refers to the use of digital health technologies that allow clinicians to observe and manage a patient's health conditions while the patient remains in their home environment. Instead of relying solely on readings captured during clinic visits, RPM gathers objective physiologic data such as blood pressure, blood glucose, weight, or oxygen saturation directly from the patient's home. These readings are transmitted securely to a clinical platform where they can be reviewed for patterns and trends over time. The purpose of RPM is not to replace face-to-face care. Rather, it extends clinical oversight into the time between visits. It allows earlier detection of meaningful changes that may not be visible during isolated office encounters. It is important to distinguish RPM from telemedicine. Telemedicine typically involves scheduled communication, video visits, or phone calls. RPM, however, centers on objective physiologic data captured in the patient's home environment. There may be no real-time conversation at all. Instead, clinicians review the incoming data according to a defined schedule and intervene when necessary. This distinction matters because RPM provides continuous clinical visibility, even when no appointment is scheduled. This image shows the pathway a remote patient monitoring reading follows from the patient to the healthcare team. The first step is the patient. They take a reading using the device, such as checking their blood pressure or stepping on a digital scale. Next, the device sends the reading automatically using Bluetooth, Wi-Fi, or a cellular network. The patient does not have to upload anything manually. The device handles the connection in the background. Third, the reading passes through what the diagram labels as a local switch, which is simply the patient's home connection point, much like how a phone connects through a router. Fourth, the data enters the secure RPM cloud system. This protected environment stores and organizes the readings so they are ready for clinical review. Finally, the information appears on the clinician's dashboard. From there, the care team can evaluate the values, identify trends, respond to alerts, and intervene when necessary. The patient's only responsibility is taking the reading. The rest happens automatically. It is important to note that some remote patient monitoring devices can continue recording and storing patient readings even when there is a temporary loss of internet connectivity. When the connection is restored, the device or platform may sync the stored readings so they can be shared with the healthcare team. However, this depends on the specific device and system being used, so it is important to understand the capabilities and limitations of the RPM technology in practice. RPM is often misunderstood as real-time monitoring, but in most implementations, it is better described as asynchronous care. The patient takes readings at home, often daily or several times per week, and those readings flow into a platform for later review. The clinician may review the data the same day, within a defined window, or during scheduled monitoring times. This matters because it clarifies expectations. RPM does not always mean a clinician is watching a live feed. It means the care team has structured access to physiologic data between visits and can intervene when patterns or thresholds suggest a meaningful change. Communication, such as a phone call, message, medication adjustment, or referral, typically occurs only when the data supports it. That model is one reason RPM can extend clinical oversight without requiring constant scheduled appointments, but it also reinforces why protocols and accountability are essential. Across multiple healthcare systems globally, pharmacists are beginning to use remote patient monitoring as part of routine clinical care. Rather than relying only on information collected during in-person visits, pharmacists can now monitor patients continuously while they are at home. This is especially relevant for chronic conditions such as hypertension, diabetes, and heart failure, where a single reading in the pharmacy or clinic does not always reflect the patient's true status. RPM allows pharmacists to observe patterns over time, identify when patients are not taking medications as prescribed, and intervene earlier when clinical changes begin to occur. As a result, the pharmacist's role is expanding beyond dispensing medications to actively managing patient outcomes between visits. When we look at international experience, we see a consistent pattern of benefit. In the United States, pharmacist-led programs that incorporate RPM have been associated with improved medication adherence and reductions in hospital admissions. In Australia, community pharmacists have used RPM to monitor blood pressure in hypertensive patients, resulting in better blood pressure control and improved adherence to therapy. In Canada, RPM has been particularly valuable in rural areas where pharmacists are able to monitor patients who may not have easy access to healthcare facilities. Similar approaches have been used in smaller and more remote regions, showing that RPM is not limited to large, high-resource settings. It can also be adapted to environments where access to care is a challenge. Before we go any further, let's take a quick moment to appreciate the history of remote patient monitoring. Early ideas about remote healthcare emerged long before digital technology existed. In 1924, Radio News published a cover imagining the radio doctor, where patients could receive medical advice using radio equipment. Although fictional, it demonstrated that remote care had been part of medical imagination for over a century. The first true step toward remote patient monitoring took place in the 1960s during NASA's Gemini program. Pictured as astronaut Virgil's Grissom, one of NASA's original Mercury 7, being fitted with biometric sensors. These sensors captured heart rate, breathing, temperature, and other physiologic data and transmitted it from space back to mission control in real time. This was the earliest practical use of continuous remote physiologic monitoring. NASA's contractor, Spacelabs Healthcare, later adapted this technology for hospitals. By the late 1960s and early 1970s, intensive care units were using telemetry systems that allowed clinicians to observe multiple patients' vital signs from a central station, similar in concept to mission control. In the following decades, advances in wireless communication, microprocessors, and sensor design brought this same concept into the home setting. By the 2000s, home-based RPM devices allowed patients to collect their own readings while clinicians reviewed them remotely. This progression forms the foundation of modern remote patient monitoring. Between the early telemetry era and modern home-based RPM, several technology shifts made remote monitoring practical at scale. Sensors became smaller and more reliable, wireless connections became common, and cloud platforms made it possible to collect, organize, and review readings for large patient populations. Today's RPM is less about a single reading and more about trends over time, alert thresholds, and structured follow-up by the care team. The COVID-19 pandemic marked a global turning point for remote patient monitoring. Almost overnight, in-person visits declined, and both patients and clinicians relied heavily on remote tools to maintain continuity of care. Many governments expanded reimbursement for virtual and remote monitoring services, creating the financial structure necessary for RPM programs to grow rapidly. For chronic diseases such as hypertension and diabetes, RPM allowed clinicians to maintain close oversight even when clinics were closed or operating with restrictions. Some programs additionally used RPM to monitor COVID-19 symptoms, enabling early detection of worsening respiratory status. This period reshaped expectations in healthcare. Remote monitoring transitioned from an optional supplement to a standard component of care. Hybrid models that combine virtual and in-person visits now persist well beyond the pandemic, reflecting RPM's established role in modern clinical practice. Home-based RPM began taking shape as personal medical devices became wireless and more affordable in the early 2000s. Blood pressure monitors, glucometers, pulse oximeters, and weight scales increasingly included Bluetooth, Wi-Fi, or cellular connectivity. This allowed patient data to move from the home directly into secure cloud systems without the patient needing any technical expertise. Around the same time, clinicians began using digital dashboards that organize incoming readings into trends, alerts, and summaries. This shift marked the transition of RPM from a hospital-based tool to an at-home solution for chronic disease management, particularly for hypertension, diabetes, heart failure, and COPD. Now that we have a clear definition of RPM and how the data moves from the home to the clinical team, the next question is simple. What tools are actually used to generate this data? In most RPM programs, the devices are familiar. Blood pressure monitors, blood glucose meters, digital weight scales, and pulse oximeters. These devices are chosen because they capture physiologic measures that matter in chronic disease monitoring and because they can be used safely by patients at home with minimal training. In many systems, the device is connected, meaning it can transmit readings electronically, often through Bluetooth, to a phone, or directly through Wi-Fi or cellular connection, so the patient does not need to write values down or manually upload anything. The key point is that RPM devices do not create clinical decisions. They simply create structured, time-stamped physiologic readings that can be reviewed and interpreted by the care team. This is why device selection matters. The goal is to capture measurements that are clinically meaningful and reasonably reliable in a home setting. Let's now take a closer look at how remote patient monitoring is applied across specific clinical conditions. Hypertension is often considered one of the most straightforward clinical applications of remote patient monitoring. Blood pressure is a physiologic parameter that naturally fluctuates throughout the day. It can also be influenced by factors such as stress, physical activity, timing of measurement, and the clinical environment. For example, some patients experience elevated readings in clinic settings due to situational anxiety. Home blood pressure monitoring can provide a more representative picture of a patient's usual patterns, particularly when measurements are taken consistently and according to recommended technique. In RPM-supported care, clinicians typically focus on trends rather than reacting to a single isolated value. A series of readings collected over time allows a clinician to assess whether blood pressure control is improving, worsening, or fluctuating. This approach may be especially useful during therapy initiation, dose adjustments, or when a patient reports symptoms such as dizziness or lightheadedness that could indicate hypotension. At the same time, blood pressure monitoring illustrates an important limitation of RPM. The reliability of the data depends heavily on technique. Proper cuff size, correct arm positioning, adequate rest time before measurement, and consistent timing are all necessary for accuracy. For this reason, patient education and reinforcement of proper technique are essential components of any monitoring program. When implemented with structure and oversight, remote monitoring can support informed clinical decision-making between visits, while still maintaining access to in-person assessment when appropriate. Diabetes is another common application of remote patient monitoring, but it introduces an important nuance. Glucose data can be highly informative. At the same time, it requires clinical context to interpret accurately. In RPM-style diabetes monitoring, patients may share readings from standard blood glucose meters or continuous glucose monitoring systems, depending on the technology available. Rather than focusing on a single high or low value, clinicians typically look for patterns over time. These patterns may include recurring hyperglycemia, post-meal spikes, or episodes of hypoglycemia, particularly overnight hypoglycemia, which can carry significant risk. Diabetes therapy adjustments are generally based on trends rather than isolated readings. However, glucose values do not explain themselves. Food intake, medication timing, physical activity, illness, and adherence all influence results. Remote monitoring can support care when it is paired with structured interpretation, clear clinical protocols, and a pathway for follow-up when readings suggest concern. The key point to emphasize is that RPM improves visibility between visits, but it does not replace clinical judgment. Interpretation and oversight remain essential components of safe diabetes management. Heart failure is a classic RPM scenario because fluid status can change quickly, and deterioration often develops over days before it becomes an emergency. A common RPM approach is daily weight monitoring, sometimes combined with blood pressure, heart rate, and symptom tracking. The clinical logic is straightforward. A rising weight trend may indicate fluid retention, which can be an early signal of worsening heart failure. But heart failure is also where we have to be disciplined about what RPM can and cannot do. Monitoring data is not treatment. Monitoring only improves outcomes when it is paired with a clear clinical response, meaning someone reviews the data, recognizes concerning trends, and acts in a timely way. That response might include a call to the patient, an urgent clinic visit, medication adjustment within an established protocol, or escalation to a prescriber. Without that workflow, RPM becomes a passive data stream. So, the balanced teaching point is that RPM can support earlier detection in heart failure, but effectiveness depends on program design, clinician accountability, and the ability to respond quickly when the data signals risk. Oxygen saturation is one of the more practical measurements that can be monitored at home using pulse oximetry. Because it is measurable outside of the clinic, it is often discussed in the context of remote patient monitoring for respiratory conditions such as COPD. In selected patients, trends in SPO2, particularly when considered alongside symptoms like increased shortness of breath or fatigue, may help identify early signs of deterioration. The emphasis here is on trends over time rather than isolated readings. At the same time, oxygen saturation readings can be influenced by several factors. Motion, poor probe placement, cold extremities, nail polish, or even device quality can affect accuracy. This reinforces an important principle of RPM. Numbers require context. Even when readings are accurate, they must be interpreted relative to the patient's established baseline and overall clinical status. A value that is concerning for one patient may be normal for another. It is also important to clearly define the boundary of remote monitoring. RPM does not replace clinical evaluation. If a patient develops worsening shortness of breath, chest pain, confusion, or other red flag symptoms, direct medical assessment is necessary. So the responsible framing is that RPM may support monitoring in selected respiratory patients, provided that safety protocols and appropriate escalation pathways are in place. Another practical use case is the period immediately after hospital discharge. This transition window is high risk because patients are adjusting to medication changes, new diagnoses, and recovery at home, often with limited support. Monitoring in this period can focus on simple physiologic markers like weight, blood pressure, oxygen saturation, or glucose, depending on the reason for admission. The reason this can matter is that early warning signals sometimes appear before the patient seeks help. If the system is designed well, clinicians can identify deterioration earlier and intervene in a measured way through follow-up calls, rapid clinic review, medication reconciliation, or escalation when appropriate. But the evidence base across post-discharge monitoring is not uniform, and results vary depending on the population, the intervention design, and whether there is an actual mechanism for timely response. So the correct teaching message is not RPM prevents readmissions. The correct message is that RPM has been studied as a tool to support safer transitions, and its impact depends heavily on implementation quality, patient selection, and follow-up capacity. RPM shifts part of monitoring into the home, which means the patient is not a passive participant. The patient's main responsibility is to take measurements correctly and consistently according to the agreed protocol. Correct technique matters. Positioning, timing, and adherence to device instructions can influence the quality of the readings. Patients also have practical responsibilities, keeping the device charged or powered, ensuring connectivity when required, and maintaining supplies when relevant. For example, test strips for glucose monitoring. In some cases, the patient may also need to confirm that measurements are actually being captured and transmitted, especially early in the program. It's worth stating this plainly. RPM is not set it and forget it. It is a structured partnership. The care team can only interpret the data that is collected, and the quality of the clinical decisions depends partly on the quality and consistency of the home measurements. Now that we've covered patient-side tools for data collection in the home, let's move to the command center where healthcare professionals view, organize, and act on that information, the RPM dashboard. An RPM program does not simply generate data. It generates a large volume of data continuously. Without structure, that data has very little value. This is where dashboards come in. An RPM dashboard is essentially the control center of the program. It brings together patient readings, alerts, and trends into a single interface so that the care team can quickly understand what is happening across their patient population. Instead of manually reviewing individual readings or trying to piece together information from different systems, the dashboard allows providers to see critical metrics at a glance. This is important because decision-making in RPM is time-sensitive. The value of RPM is not just collecting data, it is the ability to interpret that data quickly and act when necessary. A well-designed dashboard saves time, reduces workload, and improves care quality by helping providers focus on what actually requires attention. Not all data is useful. What matters in RPM is whether the data leads to action. Dashboards help convert raw readings into what we call actionable insights. For example, a single blood pressure reading may not mean much on its own, but when the dashboard shows a consistent upward trend over several days, that becomes clinically meaningful. RPM systems can highlight these patterns, identify patients who may be deteriorating, and support earlier intervention before complications occur. In more advanced systems, analytics can even predict potential issues based on trends and historical data, allowing the care team to act proactively rather than reactively. Another key point is integration. When RPM data is connected with the patient's broader medical record, it provides full clinical context, making decision-making more accurate and more efficient. So again, the value of RPM is not just in collecting data, it is in transforming that data into insight and then into action. Next, let's talk about measurement frequency, because this is where RPM becomes either clinically useful or clinically noisy. RPM programs typically use a protocol that specifies how often readings should be captured. Some conditions may call for daily measurements, for example, daily blood pressure checks in a patient whose regimen is being adjusted, while other situations may use several readings per week or periodic monitoring. It's important to recognize that frequency is not just a technical decision, it's a clinical decision. Higher frequency can improve visibility, but it can also increase patient burden and create more data for clinicians to review. And in real life, adherence varies. A patient may measure consistently for 2 weeks and then become less consistent, especially if they do not feel symptomatic. That doesn't mean RPM fails. It means the program must be designed with human behavior in mind, and the care team must interpret gaps appropriately. The goal is a schedule that is realistic, clinically relevant, and sustainable. RPM produces raw readings, but clinical care is not raw data. It's interpretation. A single elevated blood pressure reading might reflect pain, stress, poor technique, or a poorly fitted cuff. If we react to every outlier, we can create unnecessary alarm and unnecessary clinical actions. This is why the goal is not simply to collect numbers, the goal is to interpret patterns. Over time, repeated readings allow clinicians to see whether a value is persistently abnormal, trending upward, trending downward, or fluctuating in a way that suggests technique issues or inconsistent medication use. That's where RPM becomes clinically meaningful, because it allows us to move from snapshots taken during office visits to a more continuous picture of the patient's physiologic reality at home. However, the interpretation still belongs to trained clinicians. RPM supports decision-making, but it does not replace the need for clinical judgment. Most RPM systems include some form of alerting, but alerts must be understood carefully. A threshold-based alert is triggered when a reading crosses a preset cutoff, for example, a blood pressure above a certain value or an oxygen saturation below a certain value. These alerts can be clinically helpful when they are accurate and actionable, especially for safety thresholds. At the same time, thresholds can generate false alarms or frequent low-value notifications, especially when patients measure at variable times or use imperfect technique. This creates a well-described risk known as alert fatigue, where repeated alarms reduce attention and responsiveness over time. That problem is not unique to RPM. It is also documented in hospital monitoring environments. Because of this, many programs balance alerts with trend-based review. Trend review asks a different question. Is the patient moving in the wrong direction across multiple readings? In practice, safe RPM design often requires a combination: alerts for urgent thresholds and structured trend review for routine monitoring, so the program remains clinically useful without overwhelming the team. When pharmacists are part of RPM-supported care, the work is usually medication-centered and problem-solving in nature. Home readings can highlight questions that are hard to answer from a single clinic visit. Is the patient taking the medication consistently? Are they taking it at the right time? Is the dose now too strong or too weak? Are side effects quietly driving missed doses? Pharmacists also often end up addressing the practical issues that can make home data unreliable. Blood pressure is a good example. Incorrect cuff placement, wrong cuff size, measuring right after activity, or measuring inconsistently can produce readings that look clinically urgent but are really technique problems. A short intervention, reteaching technique, and standardizing timing can transform the usefulness of the data. Finally, pharmacists frequently serve as a communication bridge. That might look like summarizing a trend in plain language, flagging a potential medication-related cause, and routing a structured recommendation to the prescriber or care team. The consistent theme is that pharmacists add value when the workflow is clear, what the pharmacist reviews, what the pharmacist documents, and what gets escalated. Let's talk carefully about medication adjustment, because this is where scope and safety become especially important. In a well-structured RPM model, medication changes should not occur in response to a single unusual reading. Instead, adjustments are made after reviewing trends over time, checking the clinical context, and following a clearly defined pathway. The emphasis is on pattern recognition and structured decision-making, not reacting to isolated numbers. In many systems, pharmacists support medication changes in one of two ways. The first is a recommendation-based model. In this approach, the pharmacist reviews physiologic trends, identifies potential medication-related issues, and communicates recommendations to the prescriber. The prescriber retains responsibility for making the final adjustment. The second approach, where permitted by law and institutional policy, is protocol-based. Under a collaborative practice agreement, pharmacists may adjust medications according to predefined protocols. These protocols include clear boundaries, documentation requirements, and escalation procedures. The authority is structured and limited to what has been formally approved. Regardless of the model used, the safety principle remains the same. Patients must clearly understand what change was made, what they should monitor next, and which symptoms or readings should prompt contact with the healthcare team. RPM may increase visibility between visits, but the surrounding clinical system must provide clarity, documentation, and defined follow-up. One practical benefit of remote readings is that they can show response to a plan over time, rather than forcing the team to wait for the next scheduled visit to see whether anything improved. For blood pressure, that often means looking at repeated readings across days and weeks, focusing on the direction and stability of the trend, not reacting to every spike. For glucose, it can mean noticing repeated lows after a change, persistent morning highs, or patterns that suggest timing or adherence issues. This is also where pharmacist involvement has been studied most clearly in hypertension care. In a cluster randomized trial, home blood pressure telemonitoring combined with pharmacist case management improved blood pressure control compared with usual care over the intervention period, with improvements persisting into follow-up. A separate randomized trial using a pharmacist-led Heart 360 supported home BP monitoring approach also reported greater BP reductions and improved BP goal attainment compared with usual care. The point isn't that every setting will reproduce these results automatically. The point is that when home trends are paired with structured follow-up and medication management, teams can get a clearer view of whether the plan is working and adjust thoughtfully when it isn't. We've spent the last section looking at where RPM tends to fit clinically, conditions where home measurements can meaningfully add context between visits. Now we're going to shift from the conditions to the care team, and specifically the pharmacist's perspective. This is a natural transition because pharmacists already operate in a space where medication decisions meet real-world patient behavior, adherence, technique, side effects, and follow-up. RPM doesn't change what pharmacists know, it can change what pharmacists can see between traditional touchpoints. At this point, I want to introduce Bahamas' very own Dr. Brittany Hanna, who will guide this pharmacist segment.
Hi, good day. My name is Dr. Brittany Hanna. I'm a pharmacist who graduated with her PharmD in 2023 and have been practicing pharmacy ever since. I graduated from Loma Linda University School of Pharmacy in Loma Linda, California, and completed a postgraduate year at Desert Hospital Outpatient Pharmacy in Palm Springs, California, in ambulatory care. I've been working with RPM for about a year and a half, particularly after I completed my PharmD program, and I was given that opportunity more so and used it more heavily during my postgraduate year. So my role was, especially in ambulatory care pharmacy, is essentially provide outpatient services and do more drug therapy interventions for patients. So typically what would happen, patients would get started on new therapy and they would be referred to the pharmacy team so that we can optimize that therapy. So I did multiple different practices depending on the specialty. So I was a part of a diabetes pharmacist run clinic. I also was a part of a cardiology clinic. So I did remote patient monitoring in both of those settings. On top of that, I was in a dispensary. So not only was I doing outpatient services, but I was also counseling patients within the pharmacy area. And that was, like I said, more so heavily around my program. So I would be in multiple different places, and yet still at that pharmacy dispensary, we also had like an ambulatory care services. So we would follow up with patients who were recently transitioned or discharged from the hospital, and we would ensure that treatment that they started on at the time of discharge, that they are continued and that they're followed up. And if we need to make adjustments, then we send those recommendations to their physicians so that they can get that changed. In the state of California, pharmacists who wanted to practice had to have a PharmD. If they were grandfathered in, that was something that was established like years ago. Now it's standard of practice that you have to have a PharmD in order to practice in a pharmacy. And they were usually the ones who I interacted with. Other qualifications might include graduating from a postgraduate program, and it can be in any specialty, to be honest, as long as you have experience. There's also board certification that some pharmacists can achieve or obtain, and it can be in various different specialties. For instance, there is one for ambulatory care. So you can be a board certified ambulatory care pharmacist, while there are those who were just kind of had like general pharmacy knowledge or board certification in pharmacology. There's other different specialties such as pain management or geriatric care or like psychiatric care or psychiatric pharmacy. So it's not necessary, however, it is something that is encouraged just so that you can have more, not only just more experience, but even just more skin in the game when you're trying to make those interventions with patients and collaborating with other healthcare professionals. During my time of being heavily involved in RPM, we use two particular programs. One was called Nudge, that's the one that I used in the cardio clinic, and the other one that I used in the diabetes clinic was Goji. What I like about either of those, it's not just limited to like blood pressure monitoring. For the Goji, you can check weight, blood pressure, as well as blood sugar levels. So it just depends on what was necessary for the patient and what we needed, what information we needed in order to evaluate and assess and make those interventions between patients. So patients would have access to those remote monitoring systems on their phones. They would also receive like an actual device. So like for instance, the Goji, they would send them a blood sugar device that would be connected to cellular waves so that it can, once they take their blood sugars, it gets sent to our database or our portal. So we're able to see patients' numbers in real time. And if there were any instances of high numbers or low numbers, we receive those alerts immediately, and then we're able to contact the patient in order to find out what's going on and see what would be the best course of action to ensure that they're safe and everything is under control. How I would typically start off my day is I would get into clinic, and for the first maybe 15 to 20 minutes, look through all of our patients that one had either a red alert, so we'll have a notice saying that their numbers are either really high or really low or abnormal. Once I complete that, if there's anything that does cause for concern, I would contact that patient, find out what's going on, why they experience some of those numbers, and see what course of action we need to take. What would account for trigger a follow-up would really be how their numbers are trending. If we do notice abnormal numbers over a consistent base, over a time, a certain time period, then we would encourage them to create an appointment with us so that we can possibly adjust their medication therapy. If after I'm done with that, then we would actually have regular patients who would come into the pharmacy who would also be utilizing some of those remote monitoring systems. So we try to have a follow-up depending on where they are in their treatment. Either we'll have them every 2 weeks or every 4 weeks. And gradually, as they become more controlled, those follow-ups will extend up to 3 to 6 months until we're finally able to discharge them from the program, and we refer them back to their doctor. And doctor would then complete their own evaluations. If there were a need to start new therapy, then there is a possibility of them being readmitted or referred back to our services, just so that we can take care of that optimization of their therapy. All of the clinics I was a part of were as a result of a collaborative practice agreement. It's actually very common in the state of California. And it just depends on which state that you're in, if it's readily available. However, sometimes they still operate in some shape or form. So very familiar with it. Usually there is a protocol that is constructed between pharmacists or the pharmacy team with the physician or whoever is the practice owner. That protocol will include essentially your limits or provide you what you are allowed to do whenever you are taking care of a patient. It includes medications that can be used or prescribed to patients, furnished to patients, recommended for patients. And usually pharmacists are very much have the autonomy to make the choice when it comes to making those interventions. So there is no need for a pharmacist, if they choose to add a new therapy to a patient's regimen, there is no need for them to consult with a physician, unless it's medications that are very much possibly off-label use, or a very expensive item would fit under maybe second line or third line treatment. So it really just depends on every practice, and they would come up with their own agreement in terms of what are the limitations on a pharmacist when it comes to managing. But I've been involved with all of these clinics, and usually it's very collaborative in a way that physicians do trust the pharmacist. So if the pharmacist feels that it's necessary, usually they'll move forward with it. And if there is a reason to refer patients back, it's usually based off of just being really resistant to whatever is the current treatment. So if there needs a need for intervention, further interventions such as something more invasive, then we would need to refer them to the prescriber so that they can do further evaluations of that necessity. So it just really depends. And like I said, once it gets to a point where it's out of your scope as a pharmacist, where if patients are complaining about a new symptom or there is a progression in whatever condition that they have, now it's the pharmacist's responsibility to ensure that that information can be relayed to the prescriber, and then they can decide whether or not how they want to proceed with treatment. Usually through a medication reconciliation process. So if I do have a newer patient, then in that first meeting we do a reconciliation process, just to make sure that we have on hand what medications they are currently on. If patients aren't aware or can't recall some of the names, then we would actually contact their pharmacy to get a medication history. So we try to keep up with that, and we try to make ourselves fully aware of other physicians that they're seeing, or other specialists that they're seeing, so that if in the likelihood of them starting a new therapy, that we are able to ask them those questions. But we also try to build rapport with patients and let them know or remind them to let us know whenever they do start new therapy, just so that we are aware of particular possible interactions and we can avoid any, God forbid, anything catastrophic. So usually we try, for instance, if we do see an abnormal reading, we first would like to contact the patient themselves, find out like what are the circumstances surrounding that abnormal reading. It would usually occur within that first maybe 20 minutes or so of coming into the clinic before the start of regular patient appointments. So if we do find that it's a little bit more involved, then we either would refer them to their physician, refer them to the hospital, especially if it's an extremely abnormal reading and they are experiencing some symptoms. Or at the same time, if it is an error, then we usually try to disregard it. Now, at the same time, if patient doesn't show like they're not fully confident as to what's going on and why that reading is that high, then we would encourage them to come into the clinic so that we can possibly do a point of care, or maybe send them off to do some blood work so that we can really get a definitive answer of whether or not they needed further interventions for whatever condition that we're treating them for. It's not readily used as often. In the pharmacy that I'm in right now, we do provide services such as blood sugar monitoring or point of care and blood pressure readings. And usually that gives us the opportunity to really have that discussion in terms of management, further educate patients on abnormal readings and how is it that they can do their part to ensure that they're under control. We do talk about like what medications that they're on. Unfortunately, some patients don't remember, but if they are part of our pharmacy, then we are able to look back at their history and then kind of decide like whether or not it's the medication or if it's something else that's going on. So it's not as structured, but it is a possibility, knowing that we do have these services available. And from my experience, every time I've had a patient come into the pharmacy and we provide these services for them, and they know that they can ask their questions and really get further clarity on just their condition, they are very appreciative of that. So it's definitely a difference. So, but it's just something to build upon. Thank you. Thank you.
Okay, pharmacists, it's time to get in the ring and put that pharmacy degree to work. Let's think of ourselves as clinical pharmacists conducting rounds in our very own community pharmacy. Picture this. We are not just dispensing prescriptions. We are assessing patients, identifying risks, catching problems early, and preventing harm. Now, let's work through this case together. A 68-year-old female with hypertension, diabetes, and stage 3 chronic kidney disease. Her blood pressure is elevated in the mornings. Her fasting glucose is high, but by the afternoon, her glucose readings are low and she is becoming symptomatic. Now stop. Look carefully. What changed? A new medication was started 4 days ago, clarithromycin. Before you increase the antihypertensive and before you intensify the diabetes treatment, ask yourself one critical question. What is actually driving this change? Have you figured it out yet? I will give you 10 seconds. If you said clarithromycin, good. That is exactly the point. Clarithromycin can increase sulfonylurea levels, and in a patient with chronic kidney disease, that risk is even higher. So this is not just about knowing drug names. This is about recognizing an interaction before you create harm. The real question is not, do I intensify therapy? The real question is, do I know enough to stop, think, and make the right clinical call? This is what clinical pharmacy looks like in the community. Assess the patient. Review the medication changes, identify the risk, prevent the problem. Now be honest with yourself. Would you have caught that interaction? And are you ready to act under CPA? Because if you miss it, the patient pays for it. There is no room for guesswork. Your patients are depending on your clinical judgment, not just your ability to dispense. All right, round 2. 74-year-old male, baseline kidney function, normal for age. Now his eGFR is 28 after 3 days of dehydration. No medication changes have been made yet. Now let's go one by one. Metformin. What is the risk? Empagliflozin. What happens when the patient is volume depleted? Gabapentin. It is renally cleared. So what does that mean here? Lisinopril. Helpful long-term, yes, but during acute kidney injury? Apixaban. Do you know the dosing criteria? This is not trivia. This is not just pharmacology for an exam. This is real practice. This is where pharmacists prevent admissions. If this patient were on your RPM panel and those labs came in this morning, would you know what to hold immediately? I would give you 10 seconds to review the case, but your pharmacy line is backing up, the phone is ringing, and you are working with the slow pharmacy technician today. That is real life. So the challenge is not just knowing the answer, it is knowing how to prioritize, slow yourself down mentally, and not rush your clinical judgment when the pressure is on. Would you act or would you wait? Because that is the difference between monitoring and managing. And here is another reality. If you're practicing in a community pharmacy setting, how are you arranging for this information to be accessible to your RPM team? How else are you going to make sound clinical judgments without the full picture? If you are going to offer services like this, you need the time, the systems, and the clinical competence to do it properly. So ask yourself this. Are you ready to make time in your practice for cases like this? Or do you need to hire a trained clinical pharmacist who can? Because these patients do not need passive observation. They need clinical judgment. They need intervention. And they need it on time. Across the different conditions we discussed, RPM tends to fit best when we are measuring physiologic parameters that can be captured reliably at home. Blood pressure, glucose, body weight, and oxygen saturation are common examples because they can be measured with standardized devices and repeated over time. The key point is not the individual reading. It is the pattern that develops across days or weeks. Trends provide more clinical meaning than isolated values. Another consistent theme is that outcomes are not driven by the device itself. A device only generates data. What determines usefulness is how the program is implemented. That includes whether patients are trained properly, whether measurement technique is adequate, whether there is a defined schedule for review, and whether there are clear thresholds and escalation pathways. When those structures are weak, data can become noise. When those structures are clearly defined, the data can provide a more continuous picture of what is happening between in-person visits. Finally, RPM is not a universal solution. It must be matched carefully to the right patient in the right context with the right clinical oversight. Suitability depends on both patient capacity and system capacity. That balanced perspective is important as we transition into the next section, where we will discuss how pharmacists may intersect with RPM in a scope-aware and structured way. Okay, last one, I promise. This one is different. You are reviewing home weights, and you have been watching the trend climb slowly over 10 days. 3 pounds, then 6, now 9. He is on Lasix, Coreg, Zestral, and Aldactone. No one told you the diagnosis, but at this point, you do not need to be told. His shoes are getting tighter. His fatigue is getting worse. The weight keeps going up. This is likely fluid accumulation. This is early heart failure decompensation. And no, this is not a let's see how he looks next week situation, because if you miss this trend, the next weight may be recorded in Princess Margaret Hospital. Under CPA, what do? Do you increase the diuretic per protocol? Do you call immediately? Do you assess sodium intake? Do you escalate the case the same day? This time, I will give you 30 seconds to think it through, because the pharmacy owner has decided to invest heavily in RPM and hire more pharmacy technicians to support the workflow. That is how this works when a pharmacy is serious about clinical services. You make the space for proper evaluation, sound judgment, and timely intervention. Go ahead. Take the 30 seconds starting now. Here is the answer. This is likely worsening heart failure with fluid retention. A 9-pound increase with tighter shoes and worsening fatigue is not routine. It is a warning sign. So first, you assess urgently. You confirm the trend. You ask about shortness of breath, swelling, orthopnea, missed doses, sodium intake, and fluid intake. Now, here is the key question. Do you send him to the hospital? Not automatically, not if he is still stable, but you do act immediately. You assess, you intervene, and you escalate the same day if needed. If your CPA or protocol allows it, this is where a diuretic adjustment may need to happen promptly. If it does not, then you contact the prescriber or heart failure team the same day and escalate immediately. The point is this: you do not sit on this. You do not wait until next week. And you do not hide behind the device data without making a clinical judgment. Because if you wait, then yes, you may end up sending him to the hospital, because this, not the device, is what remote patient monitoring is meant to reveal. So are you ready to intervene? And more importantly, do you know how to intervene? This slide is here for safety and credibility. RPM is not appropriate for every scenario, and being clear about limitations is part of professional education. First, RPM is not designed for emergencies. Most programs are asynchronous, meaning data is reviewed on a schedule, not continuously. A patient with severe symptoms, such as chest pain, severe shortness of breath, syncope, or signs of stroke, requires urgent evaluation, not remote monitoring. Second, RPM depends on reliable measurements. If a patient cannot consistently perform measurements, struggles with technique, or cannot maintain connectivity, the data may be too incomplete to support safe decision-making. That is not a failure of the patient. It simply means the intervention may not fit that context without additional support. Third, RPM can become unsafe if there is no clear clinical workflow. Collecting data without defining who reviews it, when it is reviewed, and what happens when values are abnormal creates avoidable risk. So suitability is not just about the patient. It is also about whether the care system has the structure to interpret and respond appropriately. In short, RPM is a tool. It fits best when the patient and system can sustain reliable measurement and when clinical oversight and escalation pathways are clearly defined. We've worked through multiple cases. What they all demonstrate is this: RPM itself does nothing. Devices collect numbers, platforms store data, but outcomes depend entirely on what happens next. When pharmacists recognize patterns early, drug interactions, renal decline, fluid overload, intervention can prevent hospitalization and, in some cases, prevent death. At the same time, RPM is not casual work. It creates responsibility. When data are reviewed and trends are visible, failing to act appropriately can expose both the patient and the clinician to harm and potentially to legal consequences. Oversight must be structured, documented, and defensible. Yes, RPM may offer reimbursement pathways and new service models, but revenue should never be the primary lens. The primary lens is clinical safety. Used thoughtfully within scope and with clear escalation pathways, RPM gives pharmacists something powerful: visibility between visits, and with visibility comes opportunity. Opportunity to intervene earlier, opportunity to prevent deterioration, opportunity to make a measurable difference, in some cases, quite literally, to save a life. We have just examined how remote patient monitoring works from a clinical perspective. Now we shift into something much more practical and, in many ways, more demanding: the business reality. RPM is not simply a device that you give to a patient. It is a service model, and like any service model, it requires structure, staffing, and accountability. Data will come in whether you are ready or not. The real question is, who in your pharmacy is responsible for reviewing that data, interpreting it, and acting on it? If that responsibility is not clearly defined, then risk is introduced immediately. As we move through this section, I want you to think less like a clinician and more like an owner or decision maker. If readings start coming in tomorrow, who owns them in your setting? Let's walk through a typical RPM workflow because understanding the process helps clarify where responsibilities sit. First, the patient is enrolled. This includes confirming eligibility, setting expectations, and ensuring informed consent because RPM involves ongoing data collection outside the clinic. Next is device setup and basic training. This is often the make or break step. Even a high-quality device can generate poor data if technique is incorrect or the patient does not understand when and how to measure. After setup, the routine becomes straightforward. The patient takes readings, and the system transmits them electronically to a secure platform. Then comes the clinical review protocol. Programs vary, but the key is that review is not random. It should follow a defined schedule and an escalation pathway. Finally, actions taken based on RPM data should be documented, and follow-up should occur when clinically indicated. When RPM works well, it is not because the device is smart. It works because the workflow is clear, realistic, and clinically governed. Successful RPM programs are not built on enthusiasm. They are built on clarity. First, you must define your patient group. Without a clear target, the program becomes unfocused. Second, someone must be explicitly assigned to review incoming data. If everyone is responsible, then no one truly is. Third, response rules must be established in advance. What triggers action? What can wait? Fourth, documentation must be structured and consistent because once data is visible, there is an expectation that it will be acted upon and recorded. The key question here is simple. Could your pharmacy clearly answer all four of these today without hesitation? One of the most underestimated aspects of RPM is the workload it creates. RPM generates a continuous stream of data. Unlike traditional care, this data does not arrive in scheduled appointments, it arrives constantly. Every reading requires time to review, interpret, and potentially act upon. That time must come from somewhere. In a busy pharmacy setting, this means either redistributing workload or increasing staffing capacity. So consider the scenario carefully. If 20 patients are enrolled and each sends readings daily, who is reviewing that data and when does that review take place? If there is no clear answer, then the system is not yet ready. RPM introduces new responsibilities at both the ownership and staff levels. For owners, this means establishing structure, defining workflows, protecting time for review, and ensuring accountability. For staff pharmacists, the role shifts toward ongoing monitoring, interpreting trends, communicating with patients, and documenting interventions. This is not a minor adjustment to workflow. It is a meaningful expansion of clinical responsibility. You must ask yourself honestly whether your current team has both the time and the training to carry out these responsibilities safely and consistently. The quality of RPM data depends heavily on how well patients are trained at the beginning. If onboarding is rushed or inconsistent, the data collected may be unreliable. Unreliable data leads to incorrect clinical decisions, which can ultimately create risk for both the patient and the provider. Proper onboarding is therefore not optional, it is essential. Patients must understand how to use devices correctly, when to take readings, and what to do if something seems wrong. The key question is whether your team can deliver that level of training consistently for every patient. Data alone does not improve outcomes. Action does. RPM requires a structured triage system where readings are categorized and responded to appropriately. Routine values may simply be documented, while concerning trends require outreach and high-risk values demand urgent escalation. However, this system only works if it is clearly defined and consistently followed. Consider a real-world scenario. If a high-risk reading appears after hours, what happens next in your pharmacy? If that pathway is not clear, then the system is not yet safe. RPM involves the handling of sensitive patient data, which introduces important governance responsibilities. Access to data must be controlled, systems must be secure, and all actions should be traceable through audit trails. Beyond the technical aspects, accountability must be clearly defined. If a reading is missed or if data is mishandled, there must be clarity about who is responsible. This is not just a technical issue, it is a legal and ethical one. As a business owner or decision maker, you must be prepared to answer that question. RPM is often discussed in terms of new revenue opportunities, but revenue should never be the starting point. When you implement RPM, you gain visibility into a patient's health status between visits. That visibility creates responsibility. If a concerning trend is visible and no action is taken, that inaction becomes a decision in itself. Before thinking about revenue, the more important question is whether your current system is ready to safely support this level of responsibility. This is where we move from theory into reality, specifically the reality of operating in the Bahamas as a pharmacy owner. If you are thinking about starting an RPM program tomorrow, these are not abstract barriers. These are operational constraints that will immediately affect whether your program succeeds or fails. The first issue is financial. At present, there is no clearly defined reimbursement structure for pharmacist-led RPM services in the Bahamas. This means that if you implement RPM, you are responsible for determining how that service is sustained. Whether that is through private pay, bundled services, or partnerships, the financial model is not predefined, you must build it. Second, staffing responsibility is not optional. RPM generates data continuously, not just during business hours and not just during appointments. Blood pressure readings, glucose values, or weight measurements can come in at any time. Someone in your pharmacy must be clearly assigned to review that data daily, not periodically, not when convenient, but consistently. If that responsibility is unclear, then clinically significant information can be missed. Third, we have to consider connectivity. While RPM devices are designed to transmit data automatically, in our setting, connectivity is not always reliable, particularly outside of Nassau. Readings may be delayed, devices may fail to sync, or patients may have inconsistent internet access. This means that the data you receive may not always be real time, and your system must be able to account for that variability. Fourth, there is a training gap. Reviewing a single blood pressure reading is straightforward. Interpreting a trend over time, identifying whether a patient is improving, deteriorating, or fluctuating, is a different skill set. Many pharmacists have not been formally trained in this type of longitudinal data interpretation, which is central to RPM. Fifth, workflow disruption is unavoidable. Pharmacy practice is traditionally structured around discrete tasks, dispensing, counseling, and transactions. RPM introduces a continuous stream of responsibilities that do not fit neatly into that structure. Without deliberate workflow design, RPM can quickly become overwhelming rather than beneficial. And finally, liability must be acknowledged. Once patient data is visible to you, there's an expectation that it will be reviewed and acted upon appropriately. If abnormal readings are transmitted and no action is taken, that creates clinical and legal risk. In other words, once you turn RPM on, you are accountable for what it shows you. So, as you think about implementing RPM, the question is not simply whether it works clinically. The question is whether your pharmacy is operationally prepared to carry the responsibility that comes with it. Having discussed the practical realities and responsibilities, it is equally important to maintain perspective. While RPM introduces new demands, it also provides something that traditional pharmacy practice does not: continuous clinical visibility. Instead of only seeing the patient at the point of dispensing, you now have access to information that reflects what is happening between visits. This creates the opportunity for earlier intervention before problems escalate to emergency visits or hospitalizations. From a professional standpoint, this also represents an expansion of the pharmacist's role. It allows pharmacists to move further into direct patient management, supported by objective data rather than isolated encounters. At the same time, implementation does not have to be immediate or large scale. RPM can be introduced gradually, starting with a small number of patients, a single condition, or a clearly defined workflow. What ultimately determines success is not how many patients are enrolled, but whether the system is structured properly. Clear responsibilities, defined processes, and manageable scope are far more important than rapid expansion. So the goal is not to adopt RPM quickly, but to adopt it deliberately and safely. As you move into the next section, I want you to reflect on both sides: the responsibility it introduces and the opportunity it creates, and consider where you currently stand in relation to both. With that balanced perspective in mind, both the responsibilities and the opportunities, we're now going to move into the questionnaire, where you'll have a chance to reflect on your own readiness to engage in RPM within your practice. Before you complete the questionnaire, take a moment to reflect honestly on your readiness. This is not about right or wrong answers. It is about self-awareness. Consider whether you feel prepared to participate in RPM programs, communicate effectively using digital tools, and teach patients how to use monitoring devices correctly. Think about your ability to interpret incoming data safely, your readiness to take on legal and regulatory responsibility, and your capacity to lead or support implementation in your setting. Finally, consider whether your current workload allows for this additional responsibility. Your responses should reflect your current reality, not an ideal scenario. Thank you for your time and attention today. I appreciate you staying engaged through a topic that sits at the intersection of clinical care, technology, workflow, and professional practice. At this point, please remain on the session so we can complete the post-lecture questionnaire together. Finally, the content in this lecture was prepared using a combination of practice-facing guidance documents, patient safety perspectives, and published research. Once again, thank you and enjoy the rest of your day.